right, welcome everybody to the Richard Safe Workplace Lecture Series. I'm glad to have you all here today. I'm Joe Allen. I'm one of the professors here at the Rocky Mountain Center, and I'm going to introduce our illustrious speaker, Dr. Jen Taylor. I've actually worked with Dr. Taylor for about 9 years. We figured this out the other day. Been working with her for 9 years on things related to workplace safety with firefighters in particular. In fact, we actually met at an event for the first center, which she'll tell you a little bit about, which is the center that she runs at Drexel University. So Dr. Taylor is a professor at Drexel University and director of the Center for Firefighter Injuries Research and Safety Trends. I should know that without looking. I mean, I should know it. 9 years and I can't even remember. At Drexel University in Pennsylvania, she's an avid Phillies fan and Eagles fan, so she's only half happy today. Worked together for many years. She's published so much research in this area in terms of firefighter well-being, as well as all types of first responders, including EMS responders and so forth, which she'll be addressing more today. She's known throughout the country and beyond in most firefighting circles, and so she's just an amazing collaborator, a fierce friend, and I'm grateful that she can be here today to share with us some of the new things that she's doing. So without further ado, here's our illustrious speaker, Dr. Jen Taylor.
An idea is a very good word to start the wordle with, right? You know that, right? I try noise every day, and I'm waiting for that one day where noise is going to be the choice, right? So just consistency is everything. So good morning, friends. Afternoon, friends. Good day, friends, right? Emily, that's what you're saying? Okay, good day. So thanks so much for being here. I feel like I'm among friends because I've been here all week. So it's been a real neat experience for me to learn more about what the Rocky Mountain Center is doing, what the department is doing, what you all are doing. So thanks for those of you who shared insights into the work that you're doing. It's really fun to be here making new friends and spending time with old. So this isn't a lecture about Joe Allen, but having occupational health psychology and organizational science in the world of injury epidemiology and public health is a really innovative combination, and we're rocking it. So I really just enjoy working with Joe. So what I'm going to be talking to you about today is just a slice of what's in the First Center's portfolio. Let's see how I do here. Okay, right, I did it. So this is the First Center and our website, so if you want to see everything that's in our wallet, this is just a screenshot of our website, but I'm going to be focusing today on our work in violence to first responders, who are firefighters, paramedics, EMS responders, and the stress and strain that experience brings to them. I am going to share video, still images, and language that may be triggering for all of us. So I will try to give you a disclaimer before I get to that if you want to close your eyes or leave the room, and I will post some resources at the end. I do this, many of you are clinicians, so these things won't be surprising to you, but I really want to make sure we're all on the same page when I talk about violence and what I mean by that. So I also wanted to talk about how this work evolved. So it was in 2017 that the United States Fire Administration and the International Association of Firefighters, that's the North American Union for Firefighters, Paramedics, and EMTs, wanted to really get a handle on what was going on with violence to firefighters. So they funded us to do a literature review, and we did what all the geeks do, right? We went to the peer-reviewed literature and we read it. But we also went to the industrial trade or gray literature and looked at what firefighters had been saying for about 40 years. It wasn't until about 20 years after they started talking about it that researchers even picked up on it. So if you are not reading the industrial literature of the industry you care about, you are already behind. So IAFF funded us to do this work, and that laid the groundwork for the very first FEMA research and development grant to look at the EMS side of fire. So for those of you who have to write grants and are working with the fire service, there's the Assistance to Firefighter Grant Program from FEMA that has a fire prevention and safety arm for practice and a research and development arm for those types of things. $1.5 million cap on your grant, so it's good money if you can get it. And it's primarily been focused on fire suppression, turnouts, cancer, heart disease, wellness, fitness, and it has evolved. So we're very happy that we got to the first grant to look at violence, particularly on the EMS side of the work that is done in fire departments. And that is important because in a fire department that runs EMS, they have runs for fires and runs for EMS. What do you think the percentage of fire to EMS runs is in a fire department? You get a free chicken sandwich if you answer.
95 to 5.
95 fire to EMS?
No, 95 EMS to 5.
Okay, yep. In some departments, you're absolutely right, Bubba. So the national average is about 65 to 70% according to FEMA. In the departments that Joe and I work with, the big metros like Philly, San Diego, and Dallas, it's 75 to 85% of what they do. But as you will see in a slide that's coming up, we've got a little bit of a disconnect of resources in that regard. But it is their bread and butter. It is what fire departments do, not what we think they do. So we had that grant, which I'm going to talk with you about the policies that emanated from that grant. And the nice thing about the work that we do as researchers in public health is it doesn't end with the research. It needs to actually go into practice. So the IAFF, again, has funded us to take what we've developed through research and develop an online training curriculum for the fire and rescue service, and then an in-person course where they will try on things that we've developed around cultural humility and cultural competency on an EMS run, all the way through how to de-escalate patients and evasive self-defensive maneuvers that they can do to get away from things when things go wrong. So it's been a nice story with them. So in the fire-based EMS world, we see stories like this all the time in the literature. For those of you who may be following this industry, you know that just a few weeks ago, Allison Russo at FDNY in New York City was murdered in broad daylight by a man she didn't know and stabbed her right on the street as she was going to a convenience store to grab a bite to eat. So these things happen when they're on a fire run. There are stories of people setting homes on fire and then pulling out a long gun and shooting at the firefighters who are responding, and it becomes an active shooter scene. So EMS is the more intimate part of the work, and so things can happen very quickly when you're doing that type of work. We follow this, the media at the First Center, and in the last year for physical violence, there have been 300 media mentions of these events. That's a vast undercount in our assessment. And so for those of you who are here, you know about Bob Karasik's job demand control model. You know that we as people who serve the public, whether it's students or the industries with whom we work, have a high psychological load and emotional load to our work. But we also have a lot of control over the work we do, when we do it, who we do it with, how it gets done. For the fire and rescue service, they have what's called a high strain job. They have high emotional demands, but no control. They're on shifts, they must respond when they're called, they have to wake up in the middle of the night, they may be on mandatory overtime like your nurses that you're familiar with, so they don't get the proper release valve when it comes to job stress. And here's the other point of the story. So these are data from the National Fire Protection Association, that's the standards and code setting organization for the fire service. It starts at 1980. And it goes to 2019. This red line are the number of fire runs in the United States, which have gone down 55% in that interval. The blue line are the number of runs for EMS in the United States, which have gone up 387% in that time, 20% increase in the last year alone, without a concomitant increase in resources for the profession. So basically, it's the 1900s again in your fire and rescue service in the United States. We do the work on the back of the workers, and we are not staffing appropriately. So we have increasing demand for EMS services. We have insufficient human and resources, so we have not enough paramedics and EMS responders in your fire department. They do not have enough ambulances, and people are calling them for absolutely everything because we hung out the shingle that said, y'all come, right? And so that's our 911 system. And so in this mix of things, there's also the exposure to violence, because if you're having a stressful day, might you say to your spouse or partner or friend when you get home, you might not be on it, and you might be a little exacerbated, and you might yell or vent, right? If this is what you do 20, 30 times a day, your stress level is already going to be high. And then you respond to a community under tremendous stress, who you're seeing their worst day every day. And these are people who may not be connected to the healthcare system at all, and you are it. And they broke their toe 3 weeks ago, and now you're pissed because you didn't get to go to the kid who fell out the window, who really needs help. You're handling someone who should have been handled by the system. So that's another form of occupational stress that this population deals with. So huge, huge demand, not enough resources, and therefore a very high strain job. And we know from Karasic's work and the work of others that when you have a high strain job, you are more likely to have negative health outcomes like cardiovascular disease, cancer, stress as an obesogenic type of agent, and obviously there are mental health and well-being concerns too. Yay, let's sign up to be firefighters. So CDC and NIOSH define workplace violence as having a violent act, usually a physical assault or a threat of assault. And the World Health Organization expands this a little bit more to cover going to and from work, and they particularly emphasize the mental strain of work. But it was Coritas in 2009 who really created a very comprehensive picture of what workplace violence looks like. And he divided it into verbal violence, which could be words that we use, threats to come after people on the job, like I'm going to steal the drugs out of your ambulance if you don't let me in there, or I'm going to come find you and your family because I don't like the service you gave me. Sexual harassment is also a form of verbal assault. And then we have the physical violence that we're all pretty familiar with. So physical abuse, but it also includes property theft or damage. So if I steal those drugs out of your ambulance, that is also a type of physical violence. And then sexual assault. So this slide is just for the physicians and clinicians in the room, so we're all aware of when we have regular stress like our flight response, our brain, our hypothalamus detects that, we go into the particular flight or fight response and we go back to status. But when we have chronic stress, that pathway is hyperactivated, and then we start to see well-being threats and physical illness. So this is my disclaimer. I'm about to show a violent encounter, so if you want to close your eyes or step out of the room, please do so. So this is an event from one of our partners, the San Diego Fire and Rescue Department. And the setup for this is that they went to a homeless encampment in their district. There was a man who had burned his foot in his tent, and they were treating him and getting him ready for transport to the hospital. So it's important to understand in San Diego, they use a third party to do their transport. So they're all paramedics on the fire engines, but they have like AMR or another first response that actually does the pickup and transport. So here that's been established. They're preparing the patient to go to the emergency department, and you'll see in just a moment that the fire truck pulls up, which is also part of the response. Often the fire truck gets there first, and then the ambulance shows up.
No, you're not.
A medical emergency.
No, you're not. No, you're not. No, you're not. You're not a cop. They're the cops.
This is a man
It's none of your
videotaping
business.
this encounter.
Well, the fact that you're having a safety issue by standing in the street.
409.5 says I have the right to kill myself. Sorry, buddy. If you want to be a cop, why don't you fucking join the force, man? Did I interfere? I've been sitting here for 20 minutes. All right, then tell this fucking jerk off
That's the
here.
firefighter who drove the rig in.
No, it is, because you're not a cop, pal. You're not a cop, asshole. You're a fucking bald-headed fucking fat asshole. That's who you are. No. You gonna arrest me? Then arrest me. Arrest me now. 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 I know. Well, tell that fat ass, the fucking little pussy. Oh, I'm scared of a fucking camera, man. I'm scared of a camera, you bald fucking asshole. Why don't you go home and fucking molest your kid?
Okay, I'm sorry, but this is actually, is anybody an EMS responder, firefighter, or paramedic in the room? So no one's thinking of signing up, right? I understand that. So this is actually, when I ask firefighters to report verbal violence to me, they laugh. They're like, Jen, I'd have to go into the reporting system 20 times a day, right? And this is an example of the type of things that they hear from the community. This is an extreme example. This isn't even a patient. This is someone who goes out and videotapes the fire department whenever they're on a call. And so you can see that the police officers, they did a good job, right? They didn't engage, they didn't react. Like if your spouse or partner or kid came home and started talking like that to you, right? I know. That's why my face is red here. It's because I'm Scottish, but also, mom got me a couple times, right? So this is a real feeling. And so the police are trained to not engage in this type of things, but fire and EMS actually aren't trained in this type of de-escalation. But the firefighter, the captain, who was asking him to move out of the street so they could move the ambulance, he also didn't escalate, right? So they were doing the right thing. But now this patient is transported, the fire department goes back to quarters. This captain, who is the ruler of the station, is now dealing with all of that emotional load. And if he doesn't get to deal with that before they get toned out on their next run, at some point when he comes to your medical emergency, he might not be the nicest guy, right? Because he hasn't had a chance to let it go, right? So I apologize for that. I just think it's really important because people don't think about verbal violence and that we have a physiological reaction to it. And it not only hurts our physical body, but it hurts our brains. Okay, so the other type of violence that Coritas was talking about is physical violence. This is what we know and we glorify in the media. I want to show you another San Diego video. This is from Joe and my close friend Ben Vernon, who is a firefighter paramedic in San Diego, who went to a medical call at the trolley tracks close to their station. It was for an inebriated patient. And there was a bystander around who thought he could tell Ben and his crew about what this patient needed. So a lot of times it's not the patient themselves, although patients are the most common perpetrators of violence. It can be just someone who's standing around. It could be a member of the family. It could be a domestic partner. Okay, that may have been really hard to see, but you can see in the, come on slides. This is the still image of the person who stabbed Ben. So this was the bystander. He stabbed Ben 2 times, collapsed his lung, which made Ben's body crumple. So the next stab that was going to his head, he actually missed. So he jokes about that a little bit. This happened in seconds, as you can see from that event. And so while it took Ben a month to recover from his physical injuries before he could return to work, he's never recovered from this one. He considered suicide. He is still in therapy. He actually speaks on the national circuit about this event as part of his therapy. And this is where we have a physical event that results in a mental health sequelae. And then finally, I want to share our other partner. These are people that Joe and I travel the country with to talk about this issue. These are our speakers. This is Kelly Adams from the Detroit Fire Department. She is a firefighter EMT. They were called to a homeless shelter for a woman who had injured her ankle. Her boyfriend was with her. He wanted to go in the back of the ambulance for treatment. The paramedic in charge asked him not to. He took a box cutter and stabbed her partner. Her partner had defensive wounds in both hands that were significant. He was bleeding out. She pulled a chair and tried to defend herself, and he got her with the box cutter. So I share that again, not to be inflammatory, but because I need you to understand that this is real, because we're talking about it from a data perspective and sharing stories, but I want you to know that was Kelly, and she has been through numerous plastic surgeries. Some of us would like to receive Botox injections, but she has to do it just so her face isn't paralyzed, and she will do it for the rest of her life. She was given awards from her department for saving her partner's life, and then she was told to transfer to the water department. So when one is assaulted in the course of doing one's job, there may be that initial, oh, we've got you. But then fire departments really don't know what to do, and it becomes an embarrassment when someone who has been injured in the line of duty this way says, we've got to change things, and they don't have an answer. And that's what happened to Kelly. That's what happened to Ben. His department responded a little bit differently than Kelly's. So this grant, where did it go? Yeah. So okay. So let's have some audience participation. Where's my? Oh, great, Bubba. Thank you for volunteering. Okay. So this is some of the literature we looked at in that IAFF Lit Review. So a 2013 study found that blank % of EMS responders had at least one instance of physical or verbal violence in the last 12 months. What's your answer? What percentage?
I would say C.
Okay, that was not a plant. Okay, so all applaud Bubba for his fantastic entry. Okay, so you get to choose the next victim.
There you go, man.
Your name, sir?
Jake.
Jake. Okay, Jake. So, all right, let's see how you do here. So, oh wait, hang on, Jake. Don't read this one. So, when we looked at career prevalence from the peer-reviewed literature from studies, that's the prevalence we found, 57 and 93% career prevalence. This is too wide of an interval to do anything with, right? You'd be like, I'm not going to the legislature with this, right, Kurt? I know you're listening. So, and EMS is a critical part of our EMS system, so we need to really understand what the prevalence and incidents are. So, okay, so now you're going to tell me what type of violence this is, Jake?
Mm-hmm.
So upon making patient contact, the suspected patient began cursing and using racial slurs towards responders without provocation.
Verbal. B.
Survey says, fantastic, right? Give Jake, great. Round of applause. You get to choose who goes next.
Oh, yeah.
Okay, your name?
Clayton.
Clayton, all right. While assessing a patient who was intoxicated and involved in a motor vehicle accident, he grabbed my butt. He also attempted to grab my breast after that incident. What type of violence is this?
That is sexual assault and a big no-no.
Excellent. Thank you so much for that. Thank you, thank you. Okay, you're all going to get a free chicken sandwich, so just wait to the end when it's nice and cold. Okay, fantastic. Your name?
Tori.
Tori. Thank you, Tori. Okay, after the run, the patient was walking away. The boyfriend walked up to the window of the rescue asking what the patient told EMS. EMS asked the patient to back up because he was not wearing a mask. The patient then states, I'm going to shoot you. EMS drove away from the boyfriend. These are actual stories told to us by the fire service in a lockdown reporting system. So, what type of violence is this?
Let's say intimidation.
Tori. Fantastic. A round of applause for my girl, Tori. Okay, we've got one more. Why aren't we choosing the faculty? We're not going to put them on the hot seat. I'll get them later, okay? All right. Where are we?
Mumbo.
Your name?
Mumbo.
Mumbo?
Yeah.
Wonderful. Okay, so during transfer from wheelchair to gurney of a combative psych patient, I was punched in the left jaw by the patient. He threatened to assault all personnel on scene, and while I was trying to remove items from his lap so they wouldn't get dropped or broken during the transfer, he swung on me and connected. What type of violence is this? All right, you get the salad. So again, there can be verbal and physical present, right, in a lot of these encounters. So very complex. Thank you all for playing. No applause? Okay, so thank you so much for that. You can all rest easy for a while. So we used during the SAVOR project on stress and violence a locked down confidential reporting system run by the Center for Leadership and Innovation at EMS in Wisconsin. It's called CLEAR. And this is actually a patient safety reporting system, so everything's locked down under CFR 45. And what we heard from the Philly, San Diego, and fire departments who piloted this program for a year is that 40% of the events that they reported to us were only verbal violence. About 20% were only physical violence. And then another 41% were both, such as Momo was just talking about, right? So this is actually what we see in the literature, is that we see physical and verbal violence often co-occurring, but we often see verbal violence as the most commonly experienced type of event. And when we asked them to, self-report, rate the severity on a physical and mental nature of these events that they reported, when it came to physical injury severity, from the injuries they sustained during assaults, 35% of them were minor, but on the mental injury side, so the damage up here, there were much more reports of minor and moderate injuries. So this is not surprising. Our bodies are actually made to recover from the physical assaults. Our psyches, I'm not so sure about. So we talked about verbal violence and physical violence. There's also intent, right? And so unintentional violence may be when your patient is hypoglycemic and you give them some sugar, and then once they're stable, they're like, "Who are you?" and they come at you. Or our colleague Ken, is it right?
Yes.
Ken from mechanical engineering, right?
Yes.
So we give a patient who's overdosed on opioids, Narcan, to reverse it, and we've just pissed them off because we've ruined their high and whatever they spent on that, and they come out swinging. So, but those things aren't intentional. There's no evidence of premeditation in those situations. And in fact, having any of these conditions here would not rise to the level of intent. For intentional violence, we need some sort of premeditation to cause harm, injury, or death. And we've actually looked at this issue with the Philadelphia District Attorney's Office in this study called Felony Assault Should Stick. What we learned, and so we took events reported that, in Pennsylvania, I'm jumping around. In Pennsylvania, it is a felony to assault a first responder. And so when a Philadelphia firefighter was assaulted and received a lost time injury and went to court, this is what we asked the DA's office. What were the outcomes of those cases? And for the most part, these people do not get a felony sentence, and there are very good reasons why. If you're interested, you can read this paper. Most people, especially if they're first responders, get what's called Alternative Rehabilitation Disposition, or ARD. They get a get out of jail card free as long as they do like anger management courses or mental health court or whatever they need. And so they get a second chance, because a felony really ruins your life. But we've hung out a shingle for workers saying, don't worry, if you get assaulted at work, someone's going to jail for 5 years. And so their sense of justice is ruined because it's not actually what happens. So at the First Center, we've paid attention to this, and this is all a little bit about how we got here. We realized that we need to have policy that focuses on prevention, not after they're injured and assaulted and trying to get them some sort of procedural justice. We need to actually prevent the assault from occurring. I'm going to skip this slide, but I will just say this is our assessment of what's going on at the federal level. I will tell you that all of these things are recommendations about what fire departments or hospitals should do to protect their workforce. There's no script for them to work from. It just says you should have a program. So that puts the burden back on those organizations to come up with something that hopefully is evidence-based. So that's why we built the Saver Systems level checklist. Okay. So what we wanted to do is, from the literature that we looked at all those years ago, the peer review, the industrial literature, we wanted to take what firefighters had been saying about assaults and codify it into some sort of system of a checklist that they could run to make sure they had those things in place for their workers. So checklists are commonly used in healthcare for those providers in the room. If you're intubating a patient or removing, a central line, there are certain things you should do to make sure you don't kill that patient, right? So we have a lot of checklists for what people should do not to kill other people, right? But we don't have a checklist for those people who are caring for others to make sure we have their backs. That was the heuristic of what we did. We wanted it to speak to each phase of emergency response when someone is going on an EMS run, and we wanted to convene national stakeholders to help us get that done. So here is a photo. There's Joe Allen.
All right, Joe.
Katie, are you in this photo? Okay, that was before you. So Joe Allen, right? Joe Allen, right? So I said to Joe, we've got a checklist that has like 200 items on it, and we can only bring firefighters in for like 2 days, and I don't know how we're gonna get through all these items. And Joe's like, oh, let's use Thinklets. And I'm like, uh-huh. Yeah, Thinklets. It's like a chicken sandwich, just smaller, you know, and it's not like a cutlet. It's okay, anyway. So he brought in meeting science to this issue that we needed to get done. And in 2 days, we got done what it would have taken us 60 meetings and God knows how many years to get done with all of these people. And I know you can't read this, but they came from all kinds of organizations, OSHA, NIOSH, EMS, National EMS member organizations, National Fire Organizations, some old retired guys. And in yellow are fire departments that helped us develop this and their labor unions. Everything we do at the First Center is labor management, and so they were there to help us at the very beginning develop this checklist. And it went along these phases of response, even before you go, what needs to be in place in your fire department to prevent violence from happening to your member. And then as you travel to the event, what information that might be previously known would be useful for you to have before you roll up on scene, such as, we had an assault here last week, let's let you know about that. When you get there prior to making entry, do you need police there on scene? So then don't go in until they arrive. So there's some types of things called stand down where you wait for police assistance. Then you do the patient care process, you're checking the patient for weapons before you close the back of the box and have a confined space and transfer them to the ED. And then once you've handed them off at the emergency department, if you've seen or experienced the verbal violence that you saw or the physical violence you saw, are you ready to go and take your next call? So this is where we go back to Karasik, where we can't right now change the number of calls that are growing to fire departments, but we can change the way the workers respond to the workload. That is a lever we have. It's going to require some money, and it's going to require some loss of flattening of hierarchies to be sure, but it could be done. If you say to the worker, I've just been to this event where I saw my partner stabbed, I'd really like to go to EAP and get some counsel, or I'd like to just go back to quarters, or I'd like to just go home, and somebody else can come in and cover for me while I reconcile that event in my mind. And then after the event, have we actually captured the information, so when we have to go testify about what is needed and what is being experienced, we have accurate data. So that's how that ran. And so from that lovely group of people in that photo, we asked them to rate all of the items on the checklist by what is most feasible, meaning it could be done in 3 to 6 months in their fire department, and then a gradient of what would take more time. So kind of like a green light, yellow light, red light, low-hanging fruit to what's going to take a little bit more thought. And for the most part, 50% or more of the items on the checklist were considered to be something that could be done in 3 to 6 months. And so we brought these people back, just the fire departments and their unions, 2 years later, right before the pandemic started. There's Joe Allen again. Oh, and there's Katie! Yay! So we brought them back to take these 174 items that came out of that first meeting. We took the 80 that were voted as most feasible. We arranged them in the interim into themes that would be policies, and we made 8 model policies for the United States Fire and Rescue Service that are to be implemented in a fire department's policy manual as a family, not distributed among their other SOPs and SOGs. And that is what I want to talk about at this point in time. Who has a microphone?
Right here.
Let's pass that over to the faculty, please. Ken, you're a superstar. Okay, so these are the SABRE model policies, and we're going to read through them because when I was preparing for this, I'm like, this is going to be really boring. And then I thought what my students had told me about popcorn, which is not just a good source of fiber, but a good way to be quiet and have them speak. So we're going to hear from the faculty. Okay, sound good? Yeah. Okay. All right. Fantastic. So these are the 8 model policies. I'm going to give you a little bit of an introduction to each of them. So the first one is, this is in the pre-event stage. If you were setting up a new fire department and you didn't want your EMS responders to get the shnikes beat out of them, what would you do? The first thing you might do is set up a mission statement. And the goal of this mission statement reads, to promote the health and safety of members by focusing on organizational structure. This policy will establish a strong organizational commitment to emergency medical services, which will elevate and prioritize EMS work to the level fire suppression currently receives. This will support two goals: safe EMS workers and quality patient care to the community served. I know you're not firefighters, but EMS responders in fire departments are the redheaded stepchild of the fire service. They do not have the same cachet as firefighters within their departments. They know it, they feel it, they are taught it. It is part of their culture. So this is huge. And this represents the consensus of all of those people that we can do this. Okay, so Ken, I know you're chomping at the bit. So these are the components. That's the goal of the policy. These are the components that go into the fire department's policy. I click, you read, okay? All right, my brother, let's go.
1.1, the health, safety, well-being, and aftercare of our members is paramount in order to provide quality community service.
You're gonna stay on this one, please.
1.2, we value equally all duties, roles, and responsibilities in our department, and the department should include all these roles. 1.3, EMS responders, firefighters, dispatchers, and leadership will use a team-centric approach in the patient care process. 1.4, we recognize that violence is an omnipresent hazard in our work and will implement policies, procedures, and practices to prevent and respond to harm to our members.
So for those of you who are clinicians, think about your organization, your occupational medicine clinic, your hospital. Are these policies that exist in your institutions? Right, thank you for responding, those of you who have. This checklist was basically developed from Atul Gawande's checklist manifesto. So what I'm showing you today, while fit tested for fire departments, could be very equally fit tested for any inpatient, outpatient, or clinical setting. Okay, Ken, you want to keep going, or how you feeling?
Oh, I'm good.
Okay, fantastic, because we're not passing it to Emily, we're passing it to another faculty member. So when we're done, okay, here we go. Okay, no wait, he's two, he's policy two. So you stay, Ken, you're doing great. Isn't Ken doing great? So we're still in the mission statement, Ken. We're still talking about what we're trying to talk about. Okay, here we go.
1.5, regardless of rank or experience, members will or encourage or have to have the power to express any and all violence concerns to each other, to their company officers, to administration, and to the union, especially with regard to verbal and physical violence. No member shall fear harassment, embarrassment, or punishment.
This is what happens in fire departments. Some old lady, some senile old lady hit me in the eye, broke my orbital bone, and now when I go back to the station, they're like, wow, don't know how to duck. Right? And then it's just all kind of bullying and abuse, and then you're not gonna report it and you're embarrassed because you couldn't defend yourself from an old lady, right? So this needs to be part of that process.
1.6, there will be a standing joint labor management and EMS committee that meets regularly to discuss responder safety issues. 1.7, the department provides ride-alongs and fire/EMS 101 for local politicians, media, researchers, clinicians, etc.
Sorry, okay. All right, pass it. Thank you so much, Ken, for that. Obviously, he's taking voice lessons. Thank you so much. Okay, so Matt, we're going to talk a little bit. Actually, you're going to hold. We're going to take you to policy 3 because policy 2 is about adapting a common definition of violence. So I'm not going to ask you to read this. This comes from the work that we did in the literature review. We give fire departments a definition of what workplace violence is. So it's codified, it comes from the literature, it's here. We've talked a little bit about it already. The thing I want to point to is this, because what the Safer Systems Level Checklist identified is that there is no policy in the United States Fire Service on the fact that you're going to experience violence on the job and how to prevent it, and there is no training on policy. So policy is great, right? You know, Kurt has done a great job with the legislature, getting money and funds, right? And policies established. They fall apart at the implementation stage. So you have to stay with them to make sure they are implemented as intended and the money goes where you want it to go to. So training on policies, the only way that it's going to infiltrate through the organization so that the members know. Okay, so now, Matt, we're gonna talk about an issue of dispatch, the 911 call center where the calls go to. This came up very hot in our previous research as like, dispatch is sending us to stuff and we walk in and the person's got a gun and they didn't even tell us. Well, it's because dispatch doesn't know because nobody's telling them, but it's kind of a whisper down the lane. And so you blame the last person who contacted you as the person who sets this ball of error in motion when it's actually not true. So the goal of this is to establish a collaborative and communicative relationship with dispatch and law enforcement designed to provide EMS responders with ample notice, knowledge, and preparation for responding to any previously known violent location, patient, or circumstance. Okay, Matt, here we go. You need to read the number, you can just read them.
Okay, I was gonna follow Ken's lead. 'Cause
I know,
he's
it's
got
tough,
that
but you
announcer
know.
voice and everything, so.
I know, right?
The department will operationalize a flag premise history caution note in the dispatch system to alert EMS responders to previously known violent locations and individuals. The department has developed the following policy for law enforcement notification of emergency response calls that require or request law enforcement backup. And the department is equipped with the necessary resources to share radio frequency between police and fire dispatch to allow for transparent sharing of information during EMS calls that request or require police assistance. The department has developed the following dispatch policy for launching additional resources to support scene safety. If feasible, dispatchers are required to keep the caller on the line until EMS arrives to ensure information is shared correctly and effectively. Training: fire and police dispatchers, EMS responders, and law enforcement officers will receive annual training on the above policies.
Fantastic. Students, pick your next faculty member. Thank you, Matt. Okay, so now we're getting to the point where you've arrived on scene and you're assessing and communicating the scene conditions. So there are two goals here: to establish procedures for assessing scene safety and communicating needs. So if you show up and your spidey sense goes off or someone says there's a gun, you're not going to go in and initiate patient care. You're going to request for resources. And then we need standardized language to understand that everyone uses to communicate that a member is in trouble. So on Ben's video, you heard cover now, cover now, cover now. In Philadelphia, it's I need an assist. In Canada, it's 33100. There is no standard for when you call for you're in trouble and it's gonna go bad. On the fire side, we use a Mayday. We call Mayday and everybody knows all communication drops, there's a secure line, everything goes into process. But on the EMS side, it doesn't. Sir, I don't know your name.
Jeremy, thanks.
Jeremy, thank you so much. Okay, so these are the policies that we've set up to assess communication of scene conditions.
The department has invoked this policy and tools for scene assessment. The department has comprehensive policies for unit staging during events with the potential for violence. The department has initiated the following policy for EMS responders, which requires communicating scene conditions and assessing any risks to personal safety upon scene arrival. The department has developed the following policy, which outlines contextually specific scenarios that may require communicating field updates to dispatch and vice versa. The department has enacted policy that safeguard members by calling for backup at the earliest recognition of a threat.
You're doing great, Jeremy, thank you.
To enhance multi-departmental collaboration, universal codes for distress or emergency are shared between police and EMS responders. Personnel will use a department-specific term when they feel threatened and need immediate assistance. If EMS responders require additional assistance, dispatch will initiate the response of the requested agencies. In the event that verbal communication is not a safe option, there are panic button mechanisms that will signal the need for assistance. And then training fire and police dispatchers, EMS responders, and law enforcement officers will receive annual training on the above policies.
Thank you so much, Jeremy. And so there's some sort of engineering issues we need, Ken, here, where the city of Chicago, the radios that a firefighter uses don't have a distress button. Philly, they have them. It's a little red button you can press and then they know what's going on and they don't query you. In Chicago, it doesn't exist. So there needs to be standardizations of things on that as well. Okay, thank you, Jeremy. You may You may select your next colleague. So the 5th policy is about standard operating procedures during patient care. Your name, sir?
My name is also Matt.
Your name is also Matt. Oh, you've got a hard road to follow. I mean, he's an EGOT, right?
Yes.
Anybody know what that is? EGOT?
Yes.
Yeah, thank you. Okay, I just was trying to be hip. Went over like a pregnant hurdle jumper. Okay, so fantastic. So the goal here is to establish policies, procedures, and practices to protect EMS responders during patient care activities. This is the intimate time where a lot of violence is experienced. And so here are the policies according to Matt.
The following standard operating procedures have been integrated with departmental policies to support EMS responders in potentially threatening calls. If the EMS responder's safety on scene is at risk, the department has initiated a policy dealing how and when to leave the scene with or without the patient.
This is actually very important because first responders believe that their job is you, not them. And so they don't think of themselves. So we've developed a protocol. It's yourself, your partner, your patient, your stuff. Leave your gear. The department has insurance for that.
If the oxygen mask drops, please.
Oh, I love it, Matt. You've upped your game.
The following safe practice policy. What? Oh, okay.
Yep.
For patient and provider safety and security, the following policy must be followed if weapons are discovered when in transit. Can we just like put the editorial part in there, what the policy is?
Absolutely. Go ahead. We're going to have a little bit of time for Q&A.
EMS responders will request police escort and/or accompaniment for violent or arrested patients. Patients will be properly secured and/or physically or chemically sedated, restrained in the emergency vehicle using department-approved methods consistent with upholding patient and provider safety. The following policy outlines when to use restraints. In some circumstances, physical or chemical restraints may require interagency involvement, as described in the policy. If body armor is used, the department has the following policy that supports and encourages the EMS responders in their decision to don body armor. Individuals may ride in the cab or patient care compartment of the emergency vehicle at the EMS responders' discretion. Violent patients must be indicated to receiving staff at the emergency department or healthcare facility prior to arrival. During patient handoff, verbal and/or written communication will alert pertinent staff or patient or bystander violence. There is a reported policy in place to notify hospitals that an EMS responder has been injured by a patient or bystander. EMS responders will receive annual training on the above policies.
So Matt, you may have a lot to say about this, and I'll ask you to hold those thoughts when we get to the end. But this is all about communication and making sure people know what to do, because there are variances in policy about restraints, who you need to call, what authority you have, et cetera. And I know for those of you in clinical settings, restraints are a large issue, but if we're going to prevent people from getting assaulted, we need to think about restraints, body armor, those particular types of things. Okay, who's next? Matt, you get to decide.
I only see one or two others here. We haven't done Joe, but
And you are?
Andy.
Hi, Andy. Thank you. So this goal is about readiness to return to service. And when we did the assessment of whether we were ready to do this or not, this one, the team that all of those 40 people, those subject matter experts, they were not as enthusiastic that this could be done, because we don't do this in this workforce. We don't ask them if they're mentally and physically ready to return to service. So this is somewhat novel, but it's to confer autonomy and authority to the EMS responder to decide what resources they need to support their physical and psychological well-being after each and every call. It is necessary that members can recover from these occupational stressors. Remember, this is the consensus of these organizations in the fire and rescue services.
Members have the power and right to decide what physical, mental, emotional resources they need, if any, before returning to service. If resources are requested by the member, supervisors will be automatically dispatched to check in on the well-being of the EMS responder. All department members are entitled to breaks for food, restroom use, and rest during their shift.
This was the hardest one.
Units can be forcibly returned to service by their supervisor only under the following specified conditions. Supervisors will offer wellness check-ins following certain calls or circumstances that may impact EMS responders. The department will utilize after-action reviews after violent events to understand what was done well and what can be improved in future calls. Valuable information gathered from AARs will be de-identified and shared as practical learning among members. Departmental policies and procedures are subject to modifications to protect providers and will regularly consider lessons learned from AARs. Fire dispatchers, EMS responders, and supervisors will receive annual training on the above policies.
Fantastic. Thank you very much. Okay, you get to pick the next.
All right, Joe.
Okay. All right, so the seventh policy is about the reporting of violence. So when I am called to testify before city council or Congress or things like that, and they say, Jen, what is the prevalence of violence against EMS responders? I cite really large intervals like 57 to 93%. That's not really good enough. So we try to encourage fire departments who work with us to understand that if we don't know, we can't advocate. So please report these events. So to encourage members to report all incidents of verbal and physical violence experienced in the course of their job duties, this allows for the capture of data.
To uphold a safe culture of reporting within the department, we encourage EMS responders to report any and all experiences of violence, verbal or physical, regardless of whether a physical injury occurred. All reports collected, including those detailing exposure to violence, will be treated and responded to with concern, respect, diligence, and I have no idea.
Oops, sorry.
After receiving reports, the department will guide and support affected EMS responders to physical and psychological resources. All members will be periodically briefed on reported incidents involving physical and verbal violence through summary reports. The summary report will include relevant details of the incidents, in addition to resources for internal and external support. Individuals who hold supervisory positions are required to follow a policy in response to a member filing a report detailing violence. And EMS responders and supervisors will receive annual training on the above policies.
Thank you, Joe. I'll go through the last one quickly because I understand I'm a little bit over time. That's because y'all were slow. So the last goal is the mental and physical health support for the member, and the goal is to identify the resources that they can use to support their well-being as a part of the department's mission to sustain a healthy department. Mental health and physical health are equally prioritized in the department. In response to the various challenges that EMS responders face, the following policies have been adopted. And so, access to physical and psychological health support. To ensure preventive mental and post-incident needs, the department will offer diverse and comprehensive mental health support programs. We'll establish external partnerships with organizations that provide needed support. Some of those are listed here. Designate personnel who have experience working with first responders and have qualified credentials, etc. Non-punitive policy will be implemented to encourage members to notify field supervisors if they believe that their coworker is exhibiting signs of stress. Confidentiality is assured. Personnel have the right to use their department's leave time in order to maintain their psychological well-being. We know this as a mental health day. With input from EMS responders, best practices for confidential mental health support will be implemented. The department has separated EAPs from the offices of department administration to protect the EMS responders' anonymity. An advocate from the department or union will inform a member on what to expect and accompany any assaulted member to court. For assaulted responders, preparation for the judicial process and court appearances are compensable activities. Right now they have to take their own personal time. And all department members will be trained. So thank you for going through all of that with me. You've basically read the paper, so now you don't have to unless you need a sleep aid. But this actually represents what these people from fire departments, from fire and EMS agencies, and people who have been advocating for this issue, including the injured, have come up with as our SABLE model policies. And they're ready for implementation in fire departments. The last thing that I'll say, and I won't, I'll just put them up there because, okay. There's one thing about the checklist that's really important. The 80 items in the SAVIOR model policies are the responsibility of the fire department and the union. The individual EMS responder has to do nothing except for the following. A checklist with pause points. I don't know if you're familiar with pause points, But pause points are, in this case, are where the member can say to the organization, this isn't working. I showed up and you knew this was a violent scene and nobody had my back. This is an opportunity along the way of the response for them to talk about when they stop the system and say, slow down, we need a correction here. And what it does is it goes back to Karasik's model where we are giving the first responder feedback into the system, which is asking what it's asking of them, to let the people who design that system know what's not working and what is harming them. So this gives them some job control. That's the point of these pause points in the checklist. So as far as implementation is concerned, some of these things have been codified in the Philadelphia Fire Department. They developed model policies for how to help a member when they're assaulted. Dallas has done a resiliency program. We obviously have the curriculum we're working on for the IAFF, and we developed a toolkit to help others. But right when we got this done, that was February of 2020. And San Diego had just received a cruise ship that they were holding off in the harbor of COVID-19 patients. So we actually never got to implement the SABRE model policy in these 3 departments. So we are now working with departments who wish to implement these, to study these, and if we can ever get any funding, Joe will do that. Yep. These are some resources that are available to help everyone. I'm sorry that I went over time in the presentation, but we have just a couple minutes for questions, and I will hang out to hear from you, and as long as we want to have discussions today. So thank you for the chicken.
So questions for Dr. Taylor.
You might have went over this, but I didn't quite catch it. When somebody makes a call to 911, I know the codes are different for police and fire. Is there work being done on that so that the fire department doesn't show up on a violent scene? Because that seems to be what will happen a lot, and then they have to wait or they have to do something in order to make sure it's a safe.
Yeah, so dispatchers, they have a protocol that they run through to do assessment with a call. They're actually accredited by a certain entity to ask questions in a certain way. So they will ask if there are weapons or are there any concerns like that, but if nobody tells them, they're sending resources, and it happens in seconds. So the only thing is, what we identified in the SABRE systems level checklist and model policy process is that police may have that information, but it's not getting into the fire dispatch system. So we talked about intercoordination and harmonization of those dispatch systems, which are different in every state and city. Some of them talk to each other, some of them don't. So police often have that information. So what departments can do in the meantime is have a stand down policy that if you get there and you're getting information, you wait. Most metropolitan departments do not have the luxury of having police respond with them. In a place like Salt Lake City, that might be the case. In South Salt Lake, where we were the other day, they are lucky to have that, but that's not always going to be the case in large volume populations. And that's why there needs to be, at least if there was violence, it becomes a flag in the CAD system that says, oh, last week there was an issue here, and it gives us something, but it's not great. Thank you.
I'll speak loudly.
Go, Ken.
Okay, we're focusing on EMTs and they experience violence. Have you compared and contrasted the amount and type of violence maybe to police and fire?
We do no work with the police at the First Center yet.
Okay. All right, so we'll look forward to hearing.
Yeah. Nope. Yeah, so I don't know what they're, I don't know what they're experiencing, and systems like Emerge, where you can get lockdown reporting where it's not going to get back to the department, we've learned are really important things. So I don't know how police are doing that.
Yeah. One thing that might be interesting to some people that don't watch On Patrol Live and Live PD is and they're policemen with live cameras and just seeing the stuff they come across from bystanders, from people that are trying to help, and things that look safe can suddenly turn. And so it is eye-opening. You can see certain police officers that are good at de-escalating things,
Absolutely.
and some that aren't.
Sure.
But it's a really interesting thing to watch.
And that's why I showed those examples, even though like they're still kind of triggering for me, but just so people understand what's real, as opposed to, because we're so desensitized from television and other things about violence, right? But this is real. And then the problem is that it's not just once, right? That's 20 times a day for big cities. And so they don't have the recovery time. Like, we can all go and like have a coffee or chat with someone after this about, wow, that video was really upsetting, but they don't have that time.
And the other thing too is police have guns and tasers, so they can defend, and here they seem much more vulnerable.
Yeah, they are, and we don't want them to have guns and tasers, although they ask for them, but some light ballistic gear that they can't stab through, or a protective vest or a ballistic helmet might be appropriate in some situations, and there's trade-offs to that. But you know, we just saw a paramedic in New York City who was 6 months away from retirement after 30 years on the job get stabbed in broad daylight, and if she only had that lightweight technical turnout, she would have been fine. And that, you know, at some point we just have to go there.
Other questions?
I have one. So it seems that there's a lot of focus on primary trauma. What about all of the other types of exposures that EMS professionals have? Secondary trauma and that type of stuff. I could see this sort of growing a little bit in that sense. Is that something that you considered, or?
Yeah, we haven't actually done any like clinical measurement of how, I mean, we use a battery of validated psychological assessments on like burnout, anxiety, depression, intention to leave the profession through our focus and rapid programs, and all of these departments, we have those data, but I'm not a clinician, and we're not doing any treatment of these folks. We're really trying to focus on the upstream preventative space. There are plenty of resources for the fire and rescue service for people who are affected. So the IAFF has an actual treatment center where people can go and receive all of those types of things. But I don't know from any of our data about the sequelae. I know what they're telling us, and but we're really trying to get in that space of preventing it from happening in the first place. And hopefully that the psychologists and the social workers who are doing the treatment are doing their end of the job.
I'm curious what the impact of violence is on the turnover rate. I can't imagine coming to work every day and getting abused. I mean, Joe, verbally, plenty of times.
He
abuses
you every day and then you show up.
No, but seriously, I mean, it seems like there's got to be a relationship to turnover because of this.
Yeah, it's really interesting. In career departments, so paid departments where you're paid as opposed to volunteer, we don't see people leaving the job with an express, like in their exit interview, saying it's because I experienced violence. We see them bidding out of the paramedic side of the work. So everyone usually goes through firefighter school, and then if they want to get that extra pay to be a paramedic, they go to paramedic training, but you can just let your license drop and just go back to fireside. So because there are lots of benefits to being a career firefighter, and if you have the seniority to choose what work you do, then you could just opt out. On the volunteer side, who knows? Who knows? But anyone who, if you look at nursing, I think there's better data in the occupation of nursing about how experience with violence or having been involved in a medical error can make people choose to leave the profession. We do capture, do they intend to leave, but we're not necessarily capturing turnover. But sure, any negative culture in your organization is going to make you wish you were someplace else. So I think it's a really good hypothesis.
Okay, Dr. Taylor's going to stick around, but we're at time, and I know people have classes and other things they need to get to. So thank you again, Dr. Taylor.
Yeah,
for your
sure.
time
Thank
today.
you. Thank you.